Good evening, I'm Dr. Revathi. I'll be presenting the seminar on topic congenital malformations of airway and lungs. Objectives include prevalence, type of anomalies, clinical presentation, diagnosis, management, and natural course. Uh, Coming to the first case scenario, 3 months male child with smooth perinatal transition presented with the complaints of noisy breathing with respiratory distress since 2 weeks of age. There were postural variations also and gradual improving. On examination, there was tachypnea with suprasternal retractions, inspiratory stridor. What are the differentials? Before going to the differentials, we'll be discussing normal anatomy of airway. This picture is a coronal section of larynx, which is showing supraglottis, uh, which extends from infrahyoid area to the false vocal cords, and glottis is true vocal cords. Subglottis is below the true vocal cords till the cricoid cartilage. And this is a direct laryngoscopy. From anterior to posterior, we can see tongue, epiglottis, eriepiglottic folds, cuneiform tubercle, corniculate tubercles, and in the midline, we'll be seeing vestibular folds, that is false vocal cord, true vocal cords, and rima glottidis. So coming to the differentials, congenital abnormalities of airways includes in the larynx, laryngeal atresia and webs, laryngeal cleft, laryngomalacia, vocal cord paralysis, saccular cyst and laryngocele, subglottic hemangioma, and congenital subglottic stenosis. Trachea includes tracheomalacia and congenital tracheal stenosis. So coming back to the case scenario, the uh, next step laryngoscope and bronchoscopy. This is the video of bronchoscopy of the same patient. Here we can see this is a omega shaped epiglottis, and there are epiglottic folds at the ends are curved inwards, which is causing collapse of the larynx. This is due to the laryngeal decrease in the laryngeal tone. So, laryngomalacia is most common congenital airway malformation, which occurs within first 2 weeks. Stridor exacerbates on crying, agitation, and feeding. This is due to the decreased laryngeal tone, which further causes supraglottic collapse during inspiration. Stridor will be relieved on lying prone position. Diagnosis is made mainly by clinical. Laryngoscopy is done only if suspecting any complications like FTT, failure to thrive, GERD, cyanosis, and cor pulmonale, and to look for any synchronous airway anomalies, which occurs in 15 to 60%, and to rule out other differentials. Management includes supportive care, parental counseling, and treatment of complications like GERD. In severe cases, supraglottoplasty is considered. Coming to the next case scenario, 7 months old infant presented to ER with complaints of URTI for 3 days, followed by respiratory distress. There is a history of recurrent such episodes with multiple hospitalization. History of prolonged intubation for 25 days in view of severe pneumonia at 1.5 months of age. On examination, biphasic stridor, predominantly inspiratory, is noted and it increases during acute episodes. This is a bronchoscopy video. In this, we can see there is narrowing of the subglottis. So this is a subglottic stenosis, second most common congenital airway malformation. It can be congenital or acquired. Typical presentation is biphasic inspiratory stridor. Recurrent croup-like symptoms can be observed due to the edema secondary to the common cold. There is a grading system called Mayer-Cotton system where there are four grades: 1, 2, 3, 4. And in grade 1 to 2, surgical options include dilation and endoscopic laser surgery. Grade 3 and 4 includes anterior cricoid split, laryngotracheal reconstruction with cartilage graft augmentation. Other case scenario: 9 months infant presented with noisy breathing since 1 month. On auscultation, there is stridor. On examination, there is a skin hemangioma, cutaneous hemangioma, and fundus examination. This is excavation of peripapillary fundus, which is called as morning glory sign. And in the bronchoscopy, here we can see on the right side of the video, there is a redness and swelling here, which is causing narrowing of the subglottis, this part. So the diagnosis is subglottic hemangioma. It appears in the first 1 month of life, starts proliferation for next 6 to 9 months, plateau at 1 year, and further involution phase starts for next 3 to 7 years. 50% will have cutaneous hemangioma, especially in segmental distribution of beard area or ear lobule. It is associated with Faces syndrome, which is posterior fossa tumors, hemangiomas, arterial lesions of head and neck, CVS, any ear anomalies, and sternal clefts. Especially in cases of cutaneous hemangiomas, this should be suspected. Management includes oral propranolol 1 to 3 mg per kg per day for 4 to 12 months with close monitoring for bradycardia, hypotension, and hypoglycemia. In severe cases, surgery it includes intralesional steroid injection, carbon dioxide and KTP laser endoscopic excision, and tracheostomy is considered. This is an article which is published in 2019. Subglottic hemangioma masquerading as croup and treated successfully with oral propranolol. Here the child was treated for 12 months. There is a remission of this stridor. This is a follow-up image showing the improvement in right earlobe hemangioma. In follow-up, there is improvement in stridor also. This is another case, 8 months old female infant presented with complaints of cough after feeding with respiratory distress since then. There is a past history of recurrent pneumonias. On examination, intercostal retractions, tachypnea, and inspiratory stridor present. Bilateral crepitations were present more in the right side. Chest X-ray is suggestive of infiltrates in the right side, which is extending into the right lower lobe. So this is the bronchoscopy of the patient. Here we can see there is a defect in the posterior laryngeal wall. This one. This is clear now. Because of the defect in the posterior laryngeal wall, child is having recurrent episodes of infections and aspiration. So this is a laryngeal cleft, which is the defect in the posterior midline of the larynx. There are four types. Type 1 includes there is an interarytenoid notch which is extending till vocal cords. Type 2, it extends till the cricoid cartilage. Type 3, this interarytenoid notch extending till the cervical trachea. Type 4, extending till the thoracic trachea. So it is associated with tracheal agenesis, tracheoesophageal fistula, and multiple congenital anomalies. Management includes stabilization of airway, which is the first priority, followed by surgical repair in like type 3 and 4, which is the definitive procedure like surgical repair. 10 months old male infant presented with complaints of cough, cold, and fever since 2 days, followed by respiratory distress since 1 day. There are similar complaints in the past. There are three episodes till now. On examination, biphasic stridor, predominantly expiratory with expiratory wheeze is observed. In ER state, child received nebulization with SABA, salbutamol. There are worsening of symptoms. So this is the bronchoscopy. Here we can see there is a collapse of the glottis and subglottic region, causing narrowing of the glottis subglottic here. This is tracheomalacia. Tracheomalacia and bronchomalacia is combined called as chondromalacia. Most common cause of persistent wheeze in infancy and with male predominance of 2:1. On examination, expiratory monophonic wheeze is observed, which is more prominent over central airways. It includes primary, secondary. Primary is due to the congenital absence of tracheal supporting cartilages. Secondary includes esophageal atresia, staph, vascular rings, any tracheal compression from an aberrant innominate artery, any mediastinal masses, prolonged ventilation. Management includes postural drainage for the clearance of secretions. In severe cases like any cyanosis, endobronchial stents, CPAP via tracheostomy is done. Surgical options include iotopexy and bronchopexy. So, in the previous case, the child was nebulized with salbutamol. So, it is avoided due to because it decreases the airway tone, which causes exacerbation of loss of airway patency. Coming to the next case scenario, day 1 of life, male child presented with respiratory distress with increased oral secretions. On passing NG, there is resistance, only 10 centimeters is passed. Antenatal scans suggestive of polyhydramnios. On examination, anal opening is absent. Chest X-ray is suggestive of there is coiling of NG in the upper part of esophagus. So this is step. This is a picture which is showing the types from highest prevalence to the least prevalence. First one is type C, where there is an esophageal atresia with distal teph. Type A is esophageal atresia, but there is no teph. Type E, esophageal atresia is not there. There is a teph. Type B, proximal teph with esophageal atresia. Type D, esophageal atresia with proximal and distal teph. Ideally, bronchoscopy is not indicated. This is a bronchoscopy in TEF patient showing there is fistula just above the carina. This is a contrast study where the contrast-filled proximal esophageal pouch is observed. Most common congenital anomaly of esophagus is esophageal atresia. More than 90% of this are associated with TEF, with male predominance 1 in 3,500 birth. It is 50% anomalies are associated with bacterial association and charge syndrome. Clinically, child will present with frothing or bubbling from mouth and nose and respiratory distress. Management includes maintain patent airway and prone position to decrease the aspiration of the gastric contents in distal types. ET intubation and bag and mask is contraindicated in distal types. Surgical ligation with primary anastomosis is a definitive procedure. If the anesthetic ends more than 3 to 4 centimeters, then primary repair is not done and alternative procedures like lengthening procedures are done. Outcome includes 87% survival rate. First 5 years, surgery is challenging due to these complications like anastomotic leak, refistulization, anastomotic strictures, GERD, which is leading to reactive airway disease. Coming to the other topic, congenital anomalies of lung. 5 months male child presented with complaints of noisy breathing, cough since 20 days. On examination, there is decreased air entry in right mammary area and there is right monophonic wheeze. This is a chest X-ray which is suggestive of multiple cystic lesions in the right side, and this is a CT which is showing multiple cystic lesions right side of. So we the discuss genetic disorders of the lung. It includes pulmonary abscess and pulmonary hypoplasia, congenital cystic formations, pulmonary sequestration, bronchogenic cyst, congenital pulmonary lymphangiectasia, lung hernia, congenital emphysema. There are new nomenclatures like congenital small lung for pulmonary hypoplasia, congenital thoracic malformation together for the CPAM, pulmonary sequestration, and bronchogenic cyst, congenital large hyperlucent lobe for the CL. This is a presentation of congenital lung disease by different age groups. Coming to the case, the diagnosed mostly in antenatal in ultrasonography, where there will be microcystic or microcystic lesions. There are 5 types of histological patterns from type 0 to type 4, where type 1 and 4 has good prognosis, type 2 and 3 are poor prognosis, whereas type 0 it is incompatible with life. Clinical presentation depends on the size and number of lesions. In small lesions, the child will be asymptomatic till mid-childhood with episodes of recurrent persistent pulmonary infections and chest pain. Diagnosis, as I discussed before, antenatal scans by 21 weeks. Chest X-ray shows multiple cystic lesion and CT is diagnostic. Surgical resection by 1 year of age is recommended to limit the malignant potential where the pleuropulmonary blastoma is more common in these types. So this is the algorithm for management of congenital pulmonary air malformations in infants and children. Here the prenatal diagnosis of CPAM is done by antenatal scans. If it is symptomatic, then immediate thoracic imaging and DICER-1 genetic testing is done. If it is suggestive of any positive finding, then early surgical resection is done. So this DICER-1 genetic testing, this DICER-1 gene, a germline mutation, is most commonly associated with pleuropulmonary blastoma. If it is asymptomatic, then simple chest radiograph is done at birth, uh, and it is divided to low risk and high risk. If high risk with large lesions and PPB risk factor, an immediate surgery can be done. If it is under low risk, then thoracic imaging can be done within 6 months. In between, there are any symptoms or high risk characteristics, surgery can be done. If there are no risk factors and child is fine, then you can monitor for symptoms. Elective surgery should be done by 12 months of age. This is a 7-year-old child presented to ER with complaints of fever, cough, breathing difficulty since 4 days. On examination, scoliosis is present, tachypnea and intercostal retractions. There is decreased air entry in the left side. This is a chest X-ray which is showing scoliosis with homogeneous opacity in the left lower lobe, with hyperinflated lung in the right side, deviation of mediastinum towards the left side. That is a pulmonary agenesis. There are 3 types of congenital anomalies, which are agenesis, aplasia, and hypoplasia. In agenesis, lung parenchyma, bronchus, and lung vasculature are absent. Whereas in pulmonary aplasia, there will be rudimentary blind-ending bronchus. In pulmonary hypoplasia, there will be decrease in number of airway and airway generations and alveoli. Coming to the next congenital anomaly, pulmonary sequestration. There are two types, intrapulmonary and extrapulmonary, based on the vessel pleura. Based on the venous drainage to the heart, if it drains through IVC, it is extralobar. If it draining through the pulmonary veins, it is intralobar. This is a space occupying lesion within the chest, which doesn't help in gas exchange. On examination, there will be dull note on percussion with decreased breath sounds. CECT thorax shows the extent of lesion and its vascular supply. Coming to the difference, intrapulmonary pulmonary sequestration, bilateral lower lobes are most commonly involved. In extrapulmonary, males and with left lower lobe involved. It presents with lung infection, whereas extrapulmonary, most of the children will be asymptomatic and are associated with congenital diaphragmatic hernia, colonic duplication, vertebral anomalies, and pulmonary hypoplasias. In chest X-ray, in both types, there will be mass-like lesion. Treatment includes surgical removal of entire lobe in intrapulmonary due to the common sharing of visceral pleura, whereas in extrapulmonary, surgical resection of involved area can be done. And embolization is before surgical removal with decreased. Coming to the case minute 9, 3 days old male with antenatal scan suggestive of some lung abnormality, presented with complaints of respiratory distress since birth. On examination, subcostal retractions are observed and decreased left-sided breath sounds. This is a chest X-ray which is suggestive of hyperinflated lung in the left side with deviation of trachea towards the right and deviation of this mediastinum towards the right side. This is a congenital lobar emphysema where the presentation will be most common in early infancy. It can present till 5 to 6 years. Mostly it will be familial. With 50% cases, the cause will be known. Most common lobe involved is left upper lobe, which is not, with the involved lobe will be non-functional, which is not used in gas exchange. Diagnosis include prenatal, routine, antenatal scans. Shows contralateral mediastinal shift. CT chest confirms the diagnosis, and MRI, MRA can be done to look for the incompressive features. Coming to the management, this is an algorithm for evaluation treatment of CLE. In suspected CLE, if the child's age is infant's age is less than 2 months of age, then look for the chest X-ray and CT. If severe symptoms are present with chest X-ray showing severe hyperaeration, CT showing severe herniation of lung with ventilation perfusion defect, then go for the surgical excision. In more than 2 months of age, then in severe symptoms, go for the surgical excision. In mild to moderate symptoms, conservative management can be done with close follow-up. This bronchogenic cyst, it is an abnormal budding of the tracheal diverticulum, which occurs most common on the right side and near the midline structures. Symptoms include secondary to these compressive features. Typically, child presents with fever, chest pain, and productive cough. Chest X-ray shows the cyst with air fluid level, which is not compulsory. This is a cyst, and CT and MRI can be done to look for the extent of the lesion. Surgical excision can be done if there are more compressive features or symptoms which is causing distress and failure to the patient after appropriate antibiotic treatment. Take-home message includes congenital airway malformation is common. Noisy breathing, recurrent chest infections are the most common presentation. Most of them have excellent prognosis. Supportive management is the mainstay of the therapy. Thank you.